Good, good. Okay, and we're live. Passing it over to you, Zena.
Hey, good afternoon, everyone, and thank you so much for tuning in on this installment of COVID University, Health Solutions Navigating Maternal Care During COVID-19 and Beyond. Just an incredibly important topic. We've had a lot of questions about moms and babies over the past bunch of weeks, and certainly excited to hear this deck. Especially kind of proud of this group because really it was a group effort coming from the clinical providers of care. Not that all of us leadership B types doing it was not good, but I think this is, I'm especially proud of this team because they really kind of came together, dug deep, kind of got into some content and things that were new. So I use that as an example. We all want to grow in all of this process. So if you have a team and you're doing something and you want to put together something as a group and present as a group, I love that. And you know, I encourage people to come forward with those different kind of thoughts. We all become, you know, subject matter experts in doing the stuff. So please come forward. And without further ado, I will introduce Micole Galapo-Goldstein, a nurse practitioner, our clinical lead on our mommy baby programs, Ashley Meskill, director and also NP recently. Congratulations, Ashley. And Keisha Sumner, master's in public health, who came on board with Health Solutions to help with the research component of these amazing programs. So thank you all so much for putting this together, and please take it away.
Great, thank you. Hi, everyone. Thank you so much for joining us today. Our team would first like to thank Dr. Brown, Dr. Flynn, and Hallie for giving us the opportunity to present our journey of navigating maternal care during COVID-19 and beyond. The agenda for today is how did we get here? The overview, maternal morbidity and mortality in New York State, our research, Northwell guidelines, maternal care navigation program, the program development, as well as the assessments and observations. So we have a couple of cases here. Patient A, who's a postpartum patient, SA, 41 years old, status post a repeat C-section at 39 and 5 weeks, gravida 2, para 2, COVID positive, with a history of a C-section in 2015, obesity, postpartum preeclampsia, anxiety, depression, and gestational diabetes that was diet controlled. She currently is on Zoloft 150 milligrams a day, Klonopin as needed, prenatal vitamin and vitamin D daily, and probiotics. On her first follow-up call, the patient reported that she needed a new therapist, her postpartum visit was not scheduled, and she needed to schedule her postpartum glucose tolerance test. Patient B, an antepartum patient, CV, 23 years old at 34 weeks gestation, gravida 2, para 1, was COVID positive and admitted and discharged for uncontrolled diabetes. She has a history of type 2 diabetes, morbid obesity with a BMI of greater than 40. She's currently on Admelog 3 times a day before meals, which is her rapid-acting insulin, Humulin twice a day in the morning and at night, which is her long-acting insulin, and prenatal vitamins daily. On her first follow-up call, the navigator confirmed her follow-up appointments for maternal fetal appointments, as well as with a diabetes educator. She reviewed her diet, carbohydrate intake, when to take her finger sticks, made sure she had her insulin and her needles, and when to keep her log. The role of the navigators was to assess for clinical decompensation, primary care follow-up, and behavioral health follow-up. So how did we get here? Postpartum women are a vulnerable population that are at risk for severe morbidity and mortality related to hypertensive disease, behavioral health disorders, including a history of anxiety and depression, or even postpartum depression, and comorbidities of diabetes and obesity. Vulnerability in these women during this period is strongly associated with compromised long-term outcomes for the mother and child related to maternal stress, lack of sleep, lack of bonding, domestic abuse, and lack of financial support. Ashley will talk about maternal morbidity and mortality in New York State.
Thank you, Micole. So since 2010, New York State has made some improvements in reducing maternal mortality and morbidity. At that time in 2010, we were ranked 46th for mortality, maternal mortality and morbidity. In 2016, we improved that to only 30th in the nation, with continued clear racial disparities. The number of reported maternal mortalities in New York increased over time. So 15.4 deaths per 100,000 live births in a time period of 2001 to 2003 to 19.6 per 100,000 in the time period of 2014 to 2016. So within the United States, that rate has really more than doubled within that time. And in 2012 and 2014, 66% of prenatal related deaths in New York State involved a C-section. And like any procedure or surgery, this obviously increases a woman's likelihood of having complications. So there also was reviews of maternal deaths in New York State during a 2-year time period of 2012 to 2014, and it was found that the top 5 causes of the pregnancy-related deaths were embolism, hemorrhage, infection, cardiomyopathy, and hypertensive disorders. And 65% of these pregnancy-related deaths occurred within really the first week from the end of pregnancy. It was also found that the top 5 causes of pregnancy associated but not related deaths within the same time period were substance abuse, motor vehicle accidents, suicide, homicide, and cancer. It should also just be noted, that throughout the United States, C-section rates have been on the rise. They've risen 30% compared with vaginal births. And again, like I mentioned before, C-sections do carry a higher rate of maternal mortality and morbidity. So also, through New York State, although they have drastically reduced maternal mortality rates over the past 8 years, Black women in New York State are still 2 to 3 times more likely to die in childbirth than white women, and 4 times more likely to die in childbirth nationally. Next slide, please. So to continue to target maternal mortality and to reduce racial disparities in health outcomes, Governor Andrew Cuomo created the Task Force of Maternal Mortality and Disparate Racial Outcomes in April of 2018. The task force is made up of New York State Senate and Assembly members, OBGYNs, hospital representatives, midwives, doulas, and other important community stakeholders. The task force met 3 times between June and December of 2018 to come up with these recommendations that you're now seeing on the screen. The governor dedicated $8 million over a 2-year period from 2019 to currently now in 2020 to fund these initiatives. In addition to these recommendations, the governor has directed the Department of Health to explore additional multi-year interventions to address maternal mortality, including the adoption of maternity care value-based payment arrangements, examining insurance reimbursement rates for providers, expanding effective community-based services, and promoting diverse workforce development initiatives. So this is the recommendations that the task force came up with and recommended to the governor, as outlined here on the screen. So they established a statewide maternal mortality review board. They are designing and implementing a comprehensive training and education program for hospitals on implicit racial bias, establishing a comprehensive data warehouse on perinatal outcomes to really improve quality of care. They want to improve and provide equitable reimbursement for midwives, expand and enhance community health worker services in New York State, create a SUNY scholarship program for midwives to address much needed diversity, create competency-based curricula for providers, as well as medical and nursing schools. And then the last three, which is to establish educational loan forgiveness program for providers who are underrepresented in medicine and intend to practice within women's health. Convene statewide expert work groups to optimize postpartum care within our state, and promote universal birth preparedness and postpartum continuity of care. Next slide. I'm going to hand it over to Keisha now. She's going to present on our health visits program.
Thank you, Ashley. So coming off the heels of the national and state data, as well as some identified gaps within this population as evidenced in our case studies, and really pulling from the experience of our clinicians, we knew that if we were going to move forward and take the next step, we needed a model to follow. And fortunately for us, we had that model already in place. It's called Northwell Health Visits, an evidence-based universal home visitation program modeled after the Family Connect program out of Durham, North Carolina. And they've had much success in the maternal care space. This program was modeled and instituted here at Northwell to improve the quality of life, health, and wellness of the infant, mother, and family. And for those of you who are a little unfamiliar with the research, we began our enrollment in January 1st, 2019. And our population is eligible mothers who deliver at Katz Women's Hospital, whom we approach prior to discharge at the bedside to consent into our 3 research arms. And so our model is a 2 to 7 session nurse home visitation program for mothers and infants designed to identify needs, create linkages to outpatient hospitals, and create linkages to community-based services. And these visitations are pretty extensive. Our clinicians, really serve these consented families by, covering a wide range of items, such as safe sleeping, lactation consulting, safety in the home, taking baby's vitals, and sharing the timeline of milestones that the baby should reach throughout these first stages of life. It's really, really quite thorough. And based on the goals of this existing program, such as decreasing anxiety and depression, decreasing risk of severe morbidity and mortality, improving health outcomes, strengthening family relationships and increasing connections between mother and child and family, increasing family connections to the community, as well as enhancing learning readiness, we knew that we had the right formula, and we knew that we had the right formula in place for success. Next slide. With that said, Northwell Health Solutions, under the direction of Dr. Zena Brown, Medical Director, and Haley Blue, saw an opportunity to incorporate the efforts of the research to benefit all high-risk mothers related to severe morbidity and mortality. And thus, the Severe Morbidity and Mortality team at Northwell was created to address and execute a program under the guidance and recommendations of the New York State Task Force to ensure maternal safety. Next slide, and I'll turn it over to Micole.
So due to the impact of COVID-19, the Health Visits program transitioned to navigate mothers that were COVID positive, as well as mothers who were at high risks for severe morbidity and mortality, and were being discharged sooner than the usual time frame in the postpartum period. Protocols changed throughout the OBGYN department at Northwell's hospitals. Antepartum changes were made, that they reduced the number of prenatal visits, obstetrical ultrasounds, and antepartum testing procedures while maintaining safety for patients and staff. On March 23rd, they moved antepartum testing units out of the hospital into ancillary offices. On April 2nd, Northwell began COVID PCR testing off-site for mothers delivering at our hospitals. Postpartum changes that were made, that were mothers who delivered vaginally were sent home at 24 hours instead of 48 hours. Cesarean deliveries were sent home at 48 hours instead of 72 hours. And maternal and neonatal criteria checklists for early discharge were also established. On March 31st, postpartum patients were moved to a separate facility 3 hours postpartum, all mothers being tested for COVID when they were going to deliver, and the babies were being tested after 24 hours of life if mom was COVID positive. Mothers and babies were rooming together. And on March 27th, the governor of New York State and New York State Department of Health mandated that patients were allowed one support person for labor and delivery and in the immediate postpartum period. Here's a timeline that was published in an article, The Care of Pregnant Women During the COVID-19 Pandemic, Response of a Large Health System in Metropolitan New York, by Northwell Health Doctors, Dr. Nimiroff Adrian et al., in the Journal of Perinatal Medicine. Goes all the way up to April 5th. In addition to that, a hotline was created for expecting mothers to assist in answering questions and discuss concerns. Ashley will now talk about the maternal care program.
Thanks, Micole. So this slide really just gives you a great visual of the timeline from March to May, and really just how we, pivoted in March from Northwell Health visits. We started having discussions a little bit before March 16th with the OBGYN service line and their COVID response, and how we could be of assistance really, and telephonically and doing telehealth, helping to navigate these moms and babies. So like Micole said, moms were being discharged from hospitals much sooner than they normally are. And so we were really there to kind of jump in and pivot the work that we were doing to support them and the service line. So we started off doing this at Long Island Jewish, just a little, probably right at the beginning, you can see, of April. And we really started mostly with the COVID positive moms. Many times we have COVID positive and high risk moms as well too, that fall into both buckets. We have navigated as well some antepartum moms. And then upon request, from the service line, we further expanded as well. So we then went live in late April at Huntington Hospital. And then after that at Southside. We also, received some direct referrals during this COVID time directly from Phelps, Lenox, Staten Island, North Shore, and Forest Hills as well. Next slide, please. And so this just shows, as of June 4th, we've navigated a total from those 3 hospitals of 226 moms. And this slide just outlines really the eligibility for our program at this time. So in terms of high risk antepartum, postpartum moms, we're really focusing on what we've mentioned before, not only in healthy visits, but everything that the New York State Task Force has outlined as well too, and they found in their findings. So the severe maternal mortality and morbidity really diagnoses. So we're really focused on moms who who have severe hypertension or preeclampsia, hypertension that they had prior to getting pregnant, gestational hypertension, postpartum elevated blood pressure, postpartum preeclampsia. We have a lot of experience and navigate a lot of moms too in health visits with perinatal mood disorders, and do a lot of education and coordination around that. Abnormal pregnancy outcomes, diabetes, so type 1, 2, and then gestational diabetes. And then we also focus on, obviously, COVID positive moms as well. Next slide, please. So this is just kind of outlining for you really what our model is and our program is. So in terms of enrollment, not only do we get referrals directly either from our hospital partners, we'll take referrals from ambulatory practices or directly from OBGYNs as well, but we use all those diagnoses that we just talked about, specifically focused on ICD-10 codes, and we pull those into chase lists. So we actually find those patients ourselves and reach out and enroll them. So in terms of our COVID positive and high risk postpartum model, we do telephonic outreach, we do telehealth and home visits as needed. So with the COVID positive moms, we're following up in a specific time period. So at 24 hours discharge from the hospital, 48 hours discharge, we do at least 1 to 5 to 8 day call, and then a 14-day call as well too, and then home visits or telehealth within that time period as necessary. The high risk postpartum moms, we're really doing it's a little similar but different, 24-hour call, 72-hour call, weekly touch bases. We do a 3-week touch base and 30 days. And again, telehealth or home visits where necessary. And really within all that care and care management, we're providing, review of medications. We go over lactation, breast care. We help troubleshoot any breastfeeding issues there may be, talk about infection. We help manage blood pressure. We ensure and do screening for behavioral health. We also educate on postpartum depression and anxiety and just signs and symptoms to look for in case a mom starts feeling that just within the time that we're managing them or within the coming weeks after that. So a lot of just support and education with the COVID positive moms, especially I think, during the time where we were going through the surge, it was really a lot of just education on isolation as well. And, how do I breastfeed well if I'm COVID positive? So just really being there as a support to answer questions for them and kind of help them through that difficult time. Having a baby is a challenging time on top of going through a pandemic. So it was really just an honor for us to be able to do that. And then just really making sure that the moms have their follow-up appointments. So for instance, if a mom had high blood pressure, ensuring she's following up with the provider when that provider wanted to see her, or just the regular 6-week postpartum visit. We really needed to ensure that the babies had adequate follow-up. So like Micole said, being discharged 24 hours after 24 hours of life, we needed to ensure they were getting in to see the pediatrician within those very early days, just to ensure there wasn't any jaundice. They were feeding adequately. So we also helped coordinate with that because many pediatricians, even privately owned ones just around Long Island, had a lot of challenges with PPE or even being able to see COVID positive moms. So we were able to work closely with the pediatric service line just to ensure Northwell set up ways to ensure that those COVID positive moms were able to be seen. So we really made sure that happened, and then just ensure they're connected to any community resources they needed, and then collaborated with their providers and escalated as necessary. And then the final thing I think I'll just say is that we're able to provide also, like in our other TCM programs, which is just such a great service, is the access to the clinical call center. So I think especially just for these moms, just for moms and babies, you know, knowing that they have that resource or someone that they can count on to get in touch with 24 hours is really great. Next slide, and I'm going, oh, I think I'm doing, next slide, sorry, Micole. And so this just shows just kind of over time, it's just another great visual just to see, you know, really from April 1st all the way to June 4th, just how much we've increased our enrollment and the volume of patients, not only COVID positive, but also these high risk moms as well. Next slide, and I'm going to hand it back over to Micole.
Okay, thank you, Ashley. So within our program, we assessed for the following with regard to our COVID positive moms. We assessed for their COVID-19 symptoms, medication adherence, education on isolation, personal protective equipment needs, as well as ensuring testing and results for the infant. In our high-risk complications cohort, we talked to them and observed and assessed for reluctance to seek care as directed on discharge, or inability to adhere to their follow-up schedules, their adherence to appropriate monitoring of blood pressures and medication dosages. In our depression and anxiety group, their isolation within the household while caring for newborn, gestational diabetes, the assessment for adherence to appropriate monitoring of blood glucose and medication dosages, education regarding dietary needs and choices. There in the thromboembolic disease cohort, we assess for adherence to their medication, access to their medication, as well as a follow-up schedule with a hematologist. We observed the need for the following in all of these groups. In the antepartum group, we observed the need for the confirmation of their follow-up appointments with regard to maternal fetal appointments or specialist appointments. We reviewed diet, we reviewed fetal movement counts, we educate on when to call the OB, whether it's for contractions or vaginal bleeding, and we confirm their access to the medications and, of course, groceries. In our postpartum group, we observe the need for lactation with regard to breastfeeding techniques, appropriate care of the breast, education on breast pumping, diet, feeding guidelines. We confirm access and follow up with their OB. We confirm access to medications and groceries. We refer them to community programs such as WIC and food stamps, as well as postpartum, we do a lot of postpartum education. With our infants, like Ashley had said, we confirm their follow-up appointments 1 to 2 days after discharge, and we assist them when necessary to schedule those appointments. We review COVID results and the status with them. We discuss feeding questions and concerns are addressed, and we confirm follow-up appointments with specialists. Some of our babies need cardiology appointments as well as hearing and speech. So with our cases, patient A, who was the postpartum patient, SA, she was the 41-year-old status post repeat C-section at 39 and 5 weeks, gravida 2 para 2, who was COVID positive with her postpartum history of postpartum preeclampsia, anxiety, obesity, and gestational diabetes. So the care was coordinated with the patient's OB, and the patient was ultimately treated in the hospital for persistent high blood pressures and started on medication. She was referred to Northwell's Women's Heart Health Program, patient access services for a primary care doctor and a therapist at Zucker Hillside, and a reminder was given for her glucose tolerance test to have done between 6 and 12 weeks postpartum. With patient B, the antepartum patient, CV, the 23-year-old at 34 weeks gestation, Gravida 2 Para 1, COVID positive, who was admitted and discharged for uncontrolled diabetes with a history of type 2 diabetes, morbid obesity, and a BMI of greater than 40. She was referred to our Healthy Living program at Health Solutions, and we sent her a thermometer from Health Solutions, and we set her up for good outcomes in the postpartum period. The program provided follow-up in the community for support services, reinforcement of education, assessment of clinical needs of mother, and maintenance of and connection with the Northwell network. So we have some common questions that were asked by our patients that we'd like to address. So when does the COVID-19 positive mother get retested? So currently Northwell is not referring patients to retest. However, some doctor's offices are retesting independently, and when they do, we recommend that the mother follows up with the doctor who ordered the test for further instructions. Because as we know, a lot of patients are still coming back positive even after the 2-week mark. What if both partners are tested positive for COVID-19? So if a mother and her partner are confirmed COVID-19 positive, they should take all possible precautions to avoid spreading the virus to her infant, including washing their hands before touching the infant and wearing a face mask while handling the infant. Can a COVID-19 mother breastfeed her baby? So in limited case series reported to date, no evidence of virus has been found in the breast milk of women with COVID-19. For symptomatic women, we recommend pumping, and the breast milk can be fed to infants by someone other than the mother. In asymptomatic women, they can directly breastfeed with appropriate precautions using a mask and gloves. The mother should wash her hands before touching the infant and wear a face mask while handling or feeding the baby. And if expressing the milk with a manual or electric breast pump, the mother should wash her hands before touching the pump or bottle parts. And after each pumping session, all parts that encounter breast milk should be thoroughly washed and the entire pump should be appropriately disinfected per the manufacturer's instructions. How long does a COVID positive patient need to stay away from the infant and when in isolation complete? So same like our other adults, the Centers for Disease and Control recommends that improvement of symptoms for the last 7 days of their 14 days isolation and 72 hours of period fever-free without any fever-reducing medications. However, I will say that it's very interesting. Most of our moms are not symptomatic, and some of them have had in the past some symptoms, but they were like over a month prior to. So we do say 2 weeks from the positive COVID if they are asymptomatic. What are some follow-up requirements after one tested positive for COVID-19? So we tell them they should follow up with their MD or OB as instructed. Some offices are actually having a telehealth visit 1 to 2 weeks postpartum to ensure that there are no symptoms or worsening symptoms in mothers, and to notify their OB or MD with any change in status with a fever, shortness of breath, cough, GI problems, loss of taste or smell. Thank you for listening. Any questions?
Okay, thanks team for that, for that summary and presentation. So we didn't get any questions this go around, so I'm not exactly sure how that's possible because typically it's like a texting kind of frenzy of answering questions. I mean, I think, listen, just in quick summary, the high level is we have an issue, not just regionally, but nationally with maternal mortality. This is one of those things that you're like, wait a minute, mommies should have stopped dying in the dark ages, in the Middle Ages. Like, how can this be? That's something that is literally part of just regular life, which is giving birth, should result in any fatalities. And I think, Ashley, the stat that you put up around the complication rates in cesarean sections being of the highest of any surgery. And in your audience right now, you have people who, folks who are following cases that are coming out of cardiothoracic surgery. Oh, dogs. Dang it, dogs, I knew it. So Sorry. So, I think, the platform of what kind of needs to happen here is clear. And then again, you've seen a lot of the details of this program in particular, but I'm hoping for the audience, a lot of it seemed very familiar, right? Which is, here are these folks who are at risk. How do we make a connection with them that then gets them to the services they need and empowers them to do things like checking their own blood pressure, like getting on the phone with their doctor? So just, again, very powerful work. Thank you so much, Keisha and Ashley and Micole, and everyone for putting this together. I'll give it a few more seconds for questions and then hand it over to Ina to wrap us up.
So I don't see any questions. I do see a lot of comments saying thank you so much for great presentation. And that's what I would like to do. Thank you, Micole, Ashley, and Keisha for this great presentation today. I also would like to thank Dr. Brown, Dr. Flynn, Dr. Jen, and Holly for their support. Thank you all for joining us today, for your attendance and interest in this topic. Please remember to check out our education SharePoint site, where you can find all of our COVID-U presentations, as well as other helpful documents and links to great resources. And please feel free to reach out with any questions or recommendations for future topics. I think there is a question here. I'm sorry, I missed the slide about can mom breastfeed the baby if COVID positive? And Dr. Jen already answered yes. Also another question, have there been any reports of postpartum death from COVID-related illness?
I will, Is somebody else going to speak?
Go ahead, Micole.
Yeah. Okay. I know that in the beginning of when we first started getting patients that were COVID positive, there were a couple of patients that were in the ICU at LIJ. I don't know specifics of the outcomes, but there were a couple that needed extra support. But like I said, most of our patients were asymptomatic.
Yeah, that's a good question. And certainly, I mean, I think let's take that as a take-home homework item. But as of April, that was another one of these weird things where you would expect there to be some amount of postpartum death, I'm talking worldwide, and that just was not a phenomenon that was reported that you really saw. So, as of that time, but similar to the children, where it was like, well, yeah, we're not really seeing that many cases in the children, and now 2 months later, we're kind of seeing these new manifestations. So I think, we just are going to have to keep our eyes open for any additional patterns that kind of emerge for these postpartum moms.
And just to back up what Dr. Zena said, some of the early research has found that moms are doing pretty well with having COVID and being pregnant as well. And some of the early research has just found that they've been doing well. There's actually research going on that is testing out the levels of why can't I think of it? The levels.
Antibodies? You looking for antibodies?
No. Oh my gosh, I can't think of the word. Female hormones.
Hormones. There you go.
Yes. As potentially a protective factor for possibly COVID. So there's that research going on as well.
Interesting. I love this question. Will this program be offered to other hospitals soon? I feel like because we have a little time, I'm going to go ahead and read some of these questions out loud, unless Ina, you want to jump in. I feel like due to some racial ethnic disparities in more areas than others. So we started this at LIJ, so the original program, and it really was so that we could capture the most, sort of our hospital that has sort of the most diversity in its population. But good news is that, you know, based on the success of the program, like so many other things, and I think this was mentioned in the presentation, so I guess I'm repeating, have now been invited by the OB-GYN service line to provide this service across the entire organization of hospitals. So thank you so much for bringing that up. Always, we want to be mindful of how we are being the most inclusive. And then if we are really excellent in the provision of what we are doing and we take it seriously, getting that out to the other sites. So right now we are also doing, it was mentioned, Southside and then Huntington, but looking to quickly expand that to the other locations.
Another question came in. Is obesity directly linked to postpartum PEC and gestational hypertension?
So obesity is linked to cardiovascular disease, which is linked to preeclampsia and obviously, you know, hypertension, as well as diabetes.
Yeah, unfortunately, you know, and for speaking from the thick set over here, the overweight and obesity in particular tends to want to be a risk factor across all of these things. And it becomes not so much an issue of if it is a risk factor, but how strong is it associated with a bad outcome. So, you know, the most important things, you know, are kind of, as we're working with our different patients, is, you know, certainly where it's appropriate, connecting them to programs like our Healthy Living to help people start to get control of their eating, but then also lifelong establishment of, you know, good habits, because while we know that there are sort of risks that are inherent just to the increasing BMIs, there are also countervailing health benefits to just, even at that BMI, being active, walking, all of those sort of healthy, the things that we know are healthy both in pregnancy and outside of pregnancy. So good question.
I don't see any other questions, but again, thank you everybody for your attendance and participation, and thank you to the presenters and to Dr. Brown.
Okay, thank you. And looking for some of those more COVID-U ideas. We'll be announcing the next COVID-U at the town hall, but are certainly going to be looking for topics after that. So thank you, everyone. Have a great day.